Everybody. I'm Dr. Valerie Leva. I'm a clinical supervisor with BHRS, and I provide a number of other trainings for the training department, including the series for interns at BHRS, associates, and anybody who wants to view these videos in this video series. I am going to start sharing my screen. Today, we're going to talk about a topic that can be challenging to talk about. Oh my goodness, let me get to the beginning of my PowerPoint here. There we are. And we're going to talk about sexual activity and sexual functioning. This is part of the four-part series on relationships that is part of the intern training series. And we're going to talk about topics that are hard to talk about because nobody has trained you in your master's degree programs about how to talk about this unless you've gone to some very specific programs in California. And none of them are in the Central Valley. So I'm assuming none of you got training in this. Um, this program is not about sexual orientation, issues with gender identity. This is just straight up about sexual activity for all people, however they may identify. I don't typically give trigger warnings, but I just always want to say to folks, yeah, social work and clinical work is a triggering career. So learn how to take care of yourself. And if you need to pop out of this training or just leave it for a few hours and come back to it later, that's fine. So I tend to do this one live most of the time, and I don't record the live session because I want people to be able to talk and get through some of their anxiety about talking about this topic without the additional anxiety about being videoed while doing so. So let's get going. We all know the Zoom training policies. If this were live, please arrive on time, etc. But we're not going to worry about that today. So the learning objectives for today are about developing awareness around typical sexual issues that arise with individuals and couples. Understand how trauma may affect sexual functioning, and also how psychiatric meds and conditions affect sexual functioning. It's really important to know about that. And then understand how to make referrals for medication or medical treatment of sexual dysfunction. This is not something that we do as clinicians unless you're trained in it. This is not something typically our nurse practitioners or psychiatrists deal with. They will probably refer back to a primary care clinician, a primary care doctor, rather. So let's first talk about terminology and the definitions of what we're talking about. And I have a lot of references in here and links in here you can click on to get more information. So, sexuality is a person's feelings, thoughts, desires, identities, values, and behaviors around sexual functioning. So, this includes sexual identity and is sometimes related to your romantic identity. Didn't think you had one, did you? But we all do have some kind of romantic identity, and that's very culturally embedded in our context. So sexuality includes how and if we engage in sexual activity and possibly romantic activity, and what activities we enjoy and with whom we engage in them. There are also people who identify as asexual and do not have sexual desire and do not wish to engage in sexual activity. And that's part of all the ways in which we identify ourselves as human beings. So just be mindful of that as well as we go through this training. So I can't prove it, but I know it's true. I really know it's true based on my 40 years as a clinician. The more comfortable you are talking about sexual issues, the more likely clients will open up about this topic. Now, I got my MSW on the East Coast, and training is a little bit different there. And we actually had an interdisciplinary training in my MSW program on how to talk about sexuality. I went to a professional campus that had doctors, lawyers, nurses, dentists, physical therapists, I think social workers, obviously. And so we all would get into some of these interdisciplinary cross-institute courses around common topics we all had to figure out how to talk about. And this was one of them. It was really helpful for me to have that. And as my comfort grew, because I grew up in a cultural context where we didn't talk about sex, and certainly women never talked about sex, um, I grew more comfortable. My clients would open up more. And as I shifted from working with the general population to working with the Veterans Affairs population, which is mostly men, um, men talk about sex more than women do. And I had to become comfortable talking about this topic in even more detail. So that is important. And it's also important if you work with a population who has experienced trauma, because there is a lot of sexual trauma in the population of folks who have the diagnosis of PTSD and borderline personality disorder. So it's really important for us to be able to talk about it without ourselves getting triggered. So if this was a live session, We do the chat, but right now, I just want you to take a minute to think, what are some of the challenges you face when talking with adult BHRS members about sexual functioning? So we're not going to talk about talking with kids about it because that's a different training. But what are some of the challenges you face? Take a minute to think about that. Is it culture, language, gender, age? It's just not a topic you know how to talk about. Um, Sexuality is part of the human being, the human experience. So it's important that we talk about that just as we talk about the biopsychosocial, spiritual aspects of the human experience. So it's important to do that. And we're going to talk first about vocabulary. And before you say these with a client and stumble over the word or get embarrassed or flush, your face flushes, you've got to learn how to say them out loud. And we're going to use the medical terms. We're going to talk about genitals, including the vagina and the penis. We're going to talk about male and female sexual dysfunction. So we're going to talk about erectile dysfunction in men and premature ejaculation in men. We're going to talk about sexual dysfunctions in women. We're going to talk about something called vaginismus, and we're going to talk about vaginal lubrication, particularly as women age. And we're going to talk overall about orgasmic dysfunction. So start being able to say those words without stumbling over them so that you can have an adult professional conversation with your members that you see at BHRS. So, what is healthy sexual functioning? So, it is two parts. It's the ability to move through the stages of sexual desire, arousal, and orgasm. So, that's the psychological, physiological aspects of it. And it's included in the healthy sexual functioning is subjective satisfaction with the frequency and outcome of individual and partnered sexual behavior. So this was taken from the Springer Encyclopedia of Behavioral Medicine. So it's a two-parter. It's can you psychologically, physiologically get through those stages? And then does the individual then have satisfaction with essentially their sex life, is what we typically call it. So let's look at some statistics about the prevalence of sexual dysfunction in the US. And it's kind of high, higher than you might think it is, because folks don't want to talk about what doesn't work for them in terms of sexuality. So overall, this is general population figures. 31% of men have experienced some sexual dysfunction, and 43% of women do. And these factors are due to the factors that influence this rate include demographics, education, physical and psychological health, negative experiences in past sexual relationships, trauma, and overall well being. And honestly, it is also affected by mental illnesses, it's affected by uh, psychiatric medications, it's affected by general health medications as well. So there are a lot of things, a lot of factors that go into determining on a general population level, is this person having a successful, satisfying sex life? Are they having physiological issues, having psychological issues with it? And so, as mental health providers, we talk about the psychological parts of it, the mental health parts of it, and refer the rest to the appropriate provider. So let's talk about the most common male sexual functioning issues. The first is erectile dysfunction, which is the inability to achieve an erection. And because Cialis and Viagra have always, past 20 years or so have been in the marketplace, maybe even 30 years at this point, you've seen tons of commercials on TV about them. So the treatment for this is oral medications in the class of drugs that include Viagra and Cialis. The second most common male sexual functioning issue is premature ejaculation, which is the inability to delay orgasm. And there's multiple treatments, including psychological counseling. CBT is used in counseling men who have trouble with premature ejaculation. The next most common is just a low sexual drive, a lack of desire to have or engage in sexual activity. And the treatment for this is testosterone and other medications. And then there's a category of men who have what's called refractory erectile dysfunction because there's either been a physical injury to the penis, they've had gender affirming surgery, and they've had to build a penis out of skin and muscle from usually their thighs, is where that's taken from. Working in the VA, I worked with a lot of men who had penis injuries because of IEDs, explosions they were exposed to. Body armor doesn't well cover the genital area, and sometimes they had penile injuries due to that. And so the treatment for this is a penile implant, which is an inflatable device implanted in the penis that enables the man to gain an artificial erection. So it's not caused by blood flow and musculature. It's achieved by a device. And so, talking with men about this, how does this work? Um, there's a golly, in the last 10 years, there's been so much more sophistication about these devices. So be able to talk about that with gentlemen. Again, you would always refer them to a medical provider about whether it's working or not, but then the psychological aspects of it is important for us to be able to talk about in counseling. The most common female sexual functioning issues include vaginismus. Remember that word? That's vaginal or pelvic pain. It's caused by tightening of the pelvic musculature. And a lot of women, particularly after they've had pregnancies, their pelvic musculature is a little stretched. It's not as tight as it needs to be. And sometimes that can lead to vaginismus with really spasming of the musculature in the pelvic floor and in the vagina. So the treatment for this is multiple, depending on the cause, which is a treatment for all of these in women. It's not as straightforward because the research on women's sexual functioning is not as well funded as the research for men's sexual functioning. In many ways, we still have a patriarchy. So take that and do with it what you wish. In women, low sexual drive is usually related to hormones, although it can be related to other issues. And so the treatment is multiple depending on what the cause is. Low vaginal lubrication is often common in women, particularly as they age and get into perimenopausal and postmenopausal times of their lives. The treatment for this, again, is multiple depending on the cause. There are some medication treatments. There are obviously some products you can purchase that help with that. And then orgasmic dysfunction, the inability to achieve an orgasm in women, is caused by a lot of different factors, including diabetes, hypertension, PTSD, history of abuse or assault, and the use of SSRI antidepressants. Women are much more affected by psychiatric medications than men are. And sort of a hidden issue within the use of SSRIs is the impact it has on women's sexual drive. And not talked about very much. Not a whole lot of options if you need to be on those medications. So, counseling is a part of that. And so you might be involved in that. As in your mental health treatment. So, some common medications and substances that impact male sexual drive and performance include blood pressure medications, because getting an erection is in part due to blood flow to the penis, antihistamines, diuretics, antipsychotic medications, alcohol, methadone, heroin, and other substances, and then steroids and tobacco can affect male sexual drive and performance. And many men are not aware that their blood pressure medications and antihistamines can affect it, or the use of diuretics, medications to pull fluid off of the body, particularly when somebody has high blood pressure. So it's important to know that so that you can ask your client, what medications are you taking? And then you refer them to the provider, the person who wrote that prescription. So we can ask about side effects, we can ask about medications, but we don't advise people on their medications or side effects. We refer them back to the prescriber. The things we might be dealing with are the psychological factors affecting sex in men. The biggest one is fear of not being able to achieve an erection. That's you know, in other areas, once you've taken a bad fall, you're afraid of falling again. Well, once you've had not been able to achieve an erection, men develop a fear of not being able to achieve an erection again, and it results in them not being as sexually as active as they wish to be. Stress and fatigue are really big psychological factors affecting sex in men, as well as history of sexual abuse or assault. Men are a kind of hidden population in the world of survivors of sexual abuse. And so it's really important to talk with men about that or ask them the question in your assessment, because men will frequently not identify sexual abuse as what it is, being raped, being sexually abused. They say the common thought is that only happens to women. And so there's not as much language from men around describing their experiences. And quite frankly, there's not a culture for men of being able to identify as a sexual assault survivor as much as there is for women, which is a very common narrative and post-traumatic growth and managing PTSD. Another factor affecting sex and men is fear of getting a partner pregnant. And that's in many places, that's still fairly preventable. In California, it is, but in many other states, if you work in other states, birth control and family planning is not as available as it was a year ago or 2 years ago. So be mindful of that when talking with folks. Common medications impacting female sexual performance include antidepressants, anti-anxiety medication, benzodiazepines, lithium for bipolar disorder, antipsychotics for schizophrenia and bipolar disorder, the old antidepressants, the tricyclic antidepressants, which were used 30 years ago, clonidine, hormones, blood pressure medications. My goodness, women really are very much affected in their sexual desire and sexual functioning by a lot of the medications they have to take. And women frequently are not aware of these side effects. So help them become educated about it and then refer them back to their prescriber for more information about managing it. The psychological factors affecting sex in women. This is what we deal with, the stress and fatigue issues. Imagine a mom with 3 or 4 young kids at home. Maybe she does or doesn't have a partner. Maybe she is or isn't documented. Maybe her partner is or isn't documented. There's stress and anxiety in the home. Maybe they work 2 jobs. Um, and managing a household. And then imagine having a mental illness diagnosis on top of that. So this is a lot of stress and fatigue. Obviously, folks who have a history of abuse and assault um, have psychological factors that affect their sexual activity. And then again, for women, fear of getting pregnant, family planning is not as available as it used to be. And so just be mindful of that. So we would share this in the voice with voice or chat, but just I want you to think about it. What information is most important for you to know in the units you work in? Think for a minute about your client, your member population, and the units you're assigned to right now. And you can think about this too if you work in children's units, because it'll be a different training, but we need to figure out how and when to talk about sex in children's system of care, particularly with kids who've been sexually abused or assaulted or observed sexual abuse or assault. What's important for you to know in your units you work in? Is it vocabulary? Is it the medications? Is it the psychological issues? Think about where you need to tailor your learning and where you need to focus. So the question is always, well, when and how do I bring this up? And what do I ask? And why do I ask it? So, we talk about in general sexual education in youth. And one of the biggest things you do is, well, when do I talk to my kid about sex? And one of the answer is, well, when the kid brings it up. Same is true for this. One of the times to talk about this topic is when the member brings it up. Um, Another time to ask about it is when you're completing an assessment. You know, on a scale of 1 to 10, here's my sample question. A healthy sex life is important for a sense of overall well-being. On a scale of 1 to 10, how would you rate yours at this point in time, with 1 being terrible and 10 being the best you've ever experienced? Then you can ask an open-ended question. Uh, Now, you might ask a closed-ended question here. Let me reframe that. Would you like to include this in your treatment? I'm thinking of motivational interviewing. Ask, do you want to include this in treatment or not? And many people will say no, but they know that you're okay talking about it if you ask that question. They know they can bring it up later. Another time to bring up this topic is when you're reviewing medication side effects. Again, I ask clients about side effects all the time. It gives me the opportunity to say, let's make an appointment with the med clinic because it seems like you have a lot of side effects. Let's get that looked at by the prescriber. And then another time to talk about is when the client or consumer or member talks about relationships. I'd ask how satisfied are you with your sex life? Or do you engage in sexual activity? Would you like more information? Um, how satisfied you? Another question, how satisfied are you with your sex life with your partner? Have you noticed any problems with sexual desire or functioning after starting medication? Again, if yes, refer to the prescriber. So what I'd like you to do on your own is develop 3 questions to ask an adult about sexual functioning. Are you going to ask them a scaling question? Going to ask them an assessment question? Is this something you want to talk about? Is it going to be a medication question? How are your side effects? How's your sexual functioning after you started this prescription? Refer back to the prescriber. Uh, Satisfaction of life question, well-being questions. We're all human beings. We all have different aspects of who we are. Um, is this a part of your life that you want to talk about? How satisfied are you? Scale of 1 to 5, 1 to 10. So think about 3 questions you would ask an adult in your unit. That's an assessment type of question to see if they want to talk about it, because what you're communicating to them is that they can talk about it with you. Um, 95% of the time, folks at assessment will say, no, I don't want to talk about it. But you'd be surprised once you open that door, how many people will feel not comfortable talking about it, but know that they can talk about it with you. And also consider some psychoeducation about sexual functioning, even just the general definition of sexuality. It's desire, it's engaging in sex, it's achieving orgasm. A lot of folks don't have that education. More and more youth, and then becoming young adults, are learning about sex from pornography, which is so unrealistic and so does not give them good, accurate information about sexual functioning, what to expect in the context of relationships, particularly. And there's so much of it available online that it's a problem. So think about how you're going to open that door with that consumer or that BHRS member. So let's switch to a minute for a minute to talk about PTSD, trauma, and sexual functioning, because many of our consumers experience PTSD and many, many have experienced sexual assault. So PTSD avoidance symptoms in men and women have a significant effect on sexual functioning. So clients who've experienced all types of trauma, not just sexual trauma, but all types of trauma, may experience disruptions to sexual functioning because of the avoidance part of that PTSD diagnosis. They may avoid people, places, and activities that remind them of the traumatic event. They may avoid the sexual stimuli. They may avoid sexual activity altogether because it reminds them of some other kind of trauma. They may avoid aspects of sexual activity. Um, they may avoid all sexual behaviors or activities because of the trauma, whether it was a sexual related trauma or not. And many clients with PTSD will use alcohol and other drugs prior to sexual activity, which then has so many other consequences for it, right? They're not alert, they may black out, they may not remember. That puts them at risk, that makes them vulnerable, particularly in public spaces as well as private spaces. Um, so just be mindful of that when working with folks. So let's talk about PTSD and sexual functioning in men. So the PTSD avoidance and negative alterations in cognition and mood were the most commonly associated uh, factors in sexual difficulty with men with PTSD. So this is the another one of those diagnostic criteria. So the avoidance symptoms and then the negative alterations in cognitions and mood, when you are anxious, depressed, irritable all the time, or a good deal of the time, you're not likely to want to avoid, you're not likely to want to engage in sexual activity. Um, all of these symptoms affect the sexual response cycle and the emotional relationship to sexual activity. This is called sexual distress. So when our emotions are out of sync with our sexual activity is called sexual distress. And so many of the times we are the providers as mental health providers that talk about that emotional relationship to sexual activity and how to help it get more in sync. And there are treatments for this, right? We help target avoidance and negative mood symptoms by incorporating sexual exposure assignments and sexual activation exercises when important. Now, that's only if you're trained in how to do this. So you might have to refer to a specialist for this type of intervention. So PTSD treatment alone does not necessarily resolve the sexual functioning issues. And so, as you're working with a client and moving through the treatment for PTSD, maybe you're using cognitive processing therapy and they're dealing with distress tolerance and emotion regulation and mindfulness and relationships, and then talking about their narrative trauma that may heal the PTSD, or maybe you're using EMDR and you're working on the target trauma or the index trauma and resolving it that way. Don't ignore the sexual activity or the sexual functioning part of it, because those treatments alone just for PTSD are not going to resolve the sexual issue. So be mindful of that. So PTSD in sexual functioning women looks a little different. So the re-experiencing symptoms were associated with more difficulties in orgasm function and higher sexual distress in women with a history of sexual trauma. But with women with PTSD that's not related to a sexual trauma, it's interesting because women may feel emotionally or physically vulnerable during sexual activity, and that might remind them of the trauma in which they experienced vulnerability, whether it was a car accident, a combat experience, a house fire, right? And in women, this will lead to intrusive images and vulnerability related distress. So just be mindful that that's a little bit different in women. Um, Most women know that most women feel vulnerable much of the time, right? We'll have our heads on a swivel if we're walking down a street at night or coming home at 11 o'clock at night, or in situations in which we might perceive danger that men don't perceive danger in and don't have the alertness level that women tend to need to have, or we've been conditioned to have, however you might view it. So let's talk about survivors of sexual assault, males and females frequently report that being reminded of trauma during sexual activity interferes with their sexual functioning and can lead to flashbacks and dissociation while they're engaged in sexual activity. And for me, this is kind of, well, yeah, that makes sense. So here are some techniques to distract from those intrusive thoughts and images during sexual activity for folks who have PTSD due to a sexual assault. So grounding is the first one. Open your eyes if your eyes are closed. Look around the room. I tell yourself in your head, I'm here, I'm now, I'm with this person, I'm in my room, I'm in my bed, or wherever they are. Use those grounding techniques in the moment. And you will role play this with the client, and you will coach the client through using these. But those grounding techniques are really essential. Ongoing mindfulness. We know now about brain health and brain science that those mindfulness techniques and practices on a regular basis is one of the things that is going to help heal the brain as it has moved into a constant fight or flight, activation of the HPA axis, dumping cortisol and adrenaline in your system all the time that keeps you on edge, right? So mindfulness is really important. And there are a lot of support groups for women. There's survivors of incest, there's survivors of sexual abuse, there's the survivors of rape groups, there's the survivors of sexual trauma in general. So again, because of COVID, we've learned to do most things online, and there are online groups that folks can attend, so they maybe need to leave their home to do that. There are books for women that are helpful. There are books to read and workbooks for women, especially The Courage to Heal. This is a guide for women survivors of child sex abuse, and then Healing Sex, a mind-body approach to healing sexual trauma. And you might use some of these books to work with women. In particular, that you might work through chapters at a time with them in counseling if this is what you're focusing on. So you can use these books with men and modify the language a bit. There are clearly not as many books for men as there are for women, again, because there's no space for a man's narrative of being a sexual assault survivor. But there are a couple of books. One is Healing Sexually Betrayed Men and Boys, and then Beyond Betrayal, Taking Charge of Your Life After Boyhood Sexual Abuse. Um, these are obviously both deal towards sexual abuse as children. Adult men are sexually assaulted as well, because when sex is used in that way, paired with violence, it's not about sexual activity, it's about power and control. But there's not a lot of literature for men, and there's not a lot of trainings about how to talk about this with men. Um, I just have to give a shout out to Canadian Armed Forces, is where I got most of my training on how to talk with men about sexual assault. Because I worked with the military population, I did a lot of military-based trainings, and they were at a training I went to in LA, and they were on it, and they had all the materials and all the resources, and they were really far, far ahead of US Armed Forces in talking about it, or US just general mental health practices. So not in small groups, but just think for a minute. You all know mindfulness and grounding techniques. I want you to think of three techniques of grounding or mindfulness that you might use with someone who's a survivor of sexual trauma. Just take a minute to think of those. Sometimes it's as simple as the 5, 4, 3, 2, 1 technique. For other people, there are mindfulness apps. There are a lot of mindfulness apps right now. Some free, some charged, some in-app charges that have guided imagery for healing, for grounding, for being present in the moment. Those are helpful. I also want you, after you've done this training, to look up three support groups, websites, orgs, reading materials that you would share with a client. You always have to look at these materials before you share them with a client. You need to know what's in those resources so that you can be confident that you're sharing something that will be helpful with a client. So after you finish today, look this up online. There's a lot out there, and there's a lot for folks to access. So let's talk for a minute about making referrals. So when we work in the mental health world, we always rule out medical causes for everything first. So if somebody's talking about sexual dysfunction and they've never talked about it with their primary care doctor or their psychiatrist, you got to refer them over. So I typically, if somebody's in care at the med clinic, I will typically say, please talk to the psychiatrist about it. We might even make a list on their phone for them to, what do I bring up and what do I say if they feel uncomfortable or if they're hesitant to talk about it with their psychiatrist. Um, and then, if nothing else, refer to their primary care physician. Um, a lot of folks don't have the right terminology or they don't know how to describe sexual dysfunction. And so we might be providing education for them around that. There are specialists for the physiological medical parts, as well as sex therapy, which is how to not is how to talk about sex. There's again misnomers about what sex therapy is. It's about how you're talking about sex and how do you coach people into what I call satisfying, successful sexual activity. So for male sexual dysfunction, tend to go to urologist as the first specialist. Um, for female sexual dysfunction, typically the referral after a primary care doctor is to the gynecologist. And if there's not a gynecologist in the area who will address these issues, find one who is. They should be able to address it. But again, there's not as much research, there's not as much training, there's not as much funding for understanding women's sexual functioning issues. If you feel that you don't have um, the training to talk about sexual functioning. There was a slide earlier that was talking about a very specific protocol in sexual functioning, kind of coaching and training. Find somebody who is, and make sure they're certified by the American Association of Sexuality Educations, Counselors, and Therapists. There is an organization for that. The link is here. And there's local training for this. So as you build your set of skills and you find that this might be something that you want to look at, the CIIS in San Francisco offers a sex therapy certificate. It occurs on weekends and it's online, takes 3 months to get. Sorry, the last info session was March 1st. I don't know what time of year you're looking at that, but they frequently run cohorts every 3 months. I don't know the cost. It's probably a couple $1,000s or more. But if you really want to do this and serve this population in this particular way, this is really a very helpful certification to get because not many people in our area have it. And so you will become a specialist in this area and will be very helpful to the clients and consumers you see. So final thoughts. You gotta learn how to talk about this. And I hope this training has been helpful in doing this with you. The next session in this series, we started with relationships and relationship patterns, and we're talking about sexuality. The next one is hope, forgiveness, reconciliation, and healing in relationships, what these things all mean. And then the last one is going to be how to regain your relationships with family after you've had a split in the relationship due to substance use or kids removed from parents, etc. So I hope you've enjoyed the series. I hope you've enjoyed this training. There are a lot of resources in this PowerPoint, so make sure you look at them. Here are a few more that I recommend, and I hope to see you in more trainings. Take care. I'm going to stop sharing for a minute, and I hope you enjoy the rest of your day. Thank you.